It's not all just about the diagnosis, because what happens when you make a diagnosis? You have to have a treatment. If you just diagnose somebody and say, you got measles, and you walk out of the room and don't do anything, you really haven't helped the patient. And so this is heart failure patients. This is a study I did in 15,000 patients. And what you see here is BNP levels. And the way BNP works is the higher it is, the sicker you are. And what you see here is patients with the BNP is 1,700. Their death rate's the highest of all of them. It's about 7.5%. And the lower the BNP, the lower the death rate. This is the time it took for the doctor to give the treatment. So when they give the treatment at 1 hour, or on this side it's 5 hours, you can see what happens here is the death rate grows up. So if you don't know the diagnosis, you don't give the treatment, patients die. And an absolute increase in mortality from about 5% to 7.5%. That's a 50% relative increase in mortality. And that's who died this week. We're not talking about a year or 2 years from now. We're talking about the next 3 or 4 days, they're dead. Because you were slow in the emergency department to give a diuretic to a patient with heart failure. This is another study. We looked at 46,000 patients. Patients who got early treatment in the emergency room are in blue here, this teal color. Patients who got delayed treatment are in yellow. The mortality rate for delayed treatment goes from 4.3 to almost 11%. That's almost tripling the mortality. This is patients who are getting vasoactive agents, which is a drug you give to change the blood pressure in heart failure. And you can see the mortality goes up, and every single category goes up for worse outcomes. Delayed treatment, waiting around in sick patients, is really a bad thing. Nobody does it on purpose. But if you don't know the diagnosis, what are you supposed to do? Next piece is this is risk. Risk comes in all sorts of forms. This is the guidelines that we are supposed to follow, and it says the guidelines for treatment of non-STEMI, which is a kind of heart attack, is what we give, that we know that data, because the way you diagnose this kind of heart attack is a blood test, that we get that data within 30 to 60 minutes. The reality is very few hospitals can perform at that level, but this is what the guidelines recommend. The only way you're going to get those kind of numbers, as I showed you in the early data, is if you do point-of-care testing. If you're waiting for your central lab to send you a number, it ain't going to happen in that time. This is for heart failure. This is the turnaround time of 60 minutes or less. So you're seeing the trend here is all the guidelines are recommending that we get these labs quickly. And if you can't figure out, this should be your experience. Remember Judge Judy? So speed and legal liability are risks that emergency docs face. The other one is the money issue. And you guys hear that point-of-care testing is problematic because it's more expensive. This is the U.S. News and World Report. It absolutely listed my old ER by name as being overcrowded. This is what emergency departments look like on Sunday. And if you don't believe me, next Sunday go to your emergency room and tell them you got a wart. See if you're seen before 8 hours. It's the busiest day of the week. Monday's the other busy day. If you can avoid an ER on Sundays or Monday, I recommend that you do it because we're crowded out the wazoo. All the doc's offices are closed. Patients got nowhere else to go. But in those situations, it's an operational problem because when you have all these people, you need to send a few home or admit them to the hospital. And these are the numbers. I did this to justify point-of-care testing in my hospital about 15 years ago. If your average length of stay in the emergency department, and that time we had an ER with about 32 beds in it, the average length of stay is 4 hours. In other words, they come, they leave in 4 hours. I can see 152 patients a day. If I can chop off that 1 hour with point-of-care, now my average length of stay is 3 hours. I can see 228 patients a day. Let's talk economics. That's an additional 76 patients a day. I have just got free 76 more beds that I didn't have yesterday because all I did is the labs were quicker. And if you bill $250 per patient, which is really an absurdly low number because if you've ever been in the ER, you did not get a bill for $250. That's $19,000 a day more I could bill. So the idea that point-of-care testing is expensive is completely bogus by people who don't want to do it for an agenda. It is not more expensive, it's more efficient. And this goes through all the math of not collecting the money and not having insurance and not getting out early. It's still made $136,000 a year. Easily pays for its own cost. But let me talk about reality. Time and legal risk and money, that's all nice, but they don't really matter. I got a 19-year-old daughter. The last place I want her is sitting naked under a stretcher in a hall with a bunch of father rapers and mother stabbers, because in the ER, it's not all nice people. There are all sorts of crazy things that go on there, and you don't want your kids sitting there exposed to that. You don't want to sit out in the waiting room and throw up. And I'll tell you an experiment I did one time. I was at a lab director conference in front of 200 lab directors. I told them, I picked one out of the audience and I brought him up stage and I said, next to me, I said, all right, we're going to play roulette. You know what Ipecac is? It's the medicine you give your kid to make them puke if they poison themselves. So I said, I have a bottle of Ipecac here, and I will give it to you if you will, and I'll give you $10 if you drink it in front of 400 people. He said, no way. I said, what's it going to take? And so I took a collection from the audience, which is the most hilarious thing you ever saw, because everybody's going, I'll give him $50. You know what we got to before he was willing to take that on stage and throw up in front of 400 people he didn't know? It was $1,000. He wouldn't do it for $500. So it came out to be $1,000 is the value of vomiting in public if you're a normal person. So who wants to do that? Nobody. But I will promise you, in the ER, at your hospital, wherever you live, there is somebody sitting in the waiting room now with a bucket, throwing up in front of all these people they don't know. And it's the most egregious thing that we could do to somebody, but it's what we do. It's the way ERs are run, and that's what happens when you don't move them through quickly. They wait in the waiting room. This is from Press Ganey, which does a lot of patient satisfaction callbacks to patients who've been in the ER to see how they're doing. And the longer you stay in the ER waiting, the less satisfied people are. So these are the numbers. If you're out in an hour, 90% are satisfied. That makes sense. If you're longer than 4 hours, 1 out of 4 hate you. Those are the realities of patient care, and I don't blame them. I've been an ER patient. I don't like waiting either. Here's the issue for emergency departments, is that who's driving away? I will tell you, the person you give a bucket and say, go back to the waiting room, if they got a Mercedes, they get it and they drive down to the next hospital. Because what's left is anybody with a wallet or a nice car leaves, and you're left with those people who came by ambulance or can't afford to go. They got to walk to the next hospital. They don't. So you're killing yourself from a financial point of view if you're a hospital, because all you got is the man with the box. These are a true story. I started the Cleveland Clinic about 15 years ago. I wasn't sure that we could actually do an ER in a city that was pretty packed. And so I went into the other ERs and sat in waiting room and found out that they were overcrowded and they really didn't take care of their patients well. And so I figured, well, we can just provide a good service and we'll see what happens next. And this is what happened next. Mount Sinai was about a mile away. It was a 250-bed hospital that had every major residency. It's a teaching program. It's a famous hospital. They went out of business in 3 years. St. Alexis was about 3 miles away, a nice little neighborhood hospital, but the patients were not being cared for very well. They stayed forever in their waiting room. What happened to them? They went out of business. The point is, if a hospital tells me they can't take care of their patient, my answer is, I'll be glad to do it for you. The trouble is those hospitals that left, all those people now don't have jobs. They came in, some of them went to hire for us, and they lose their pension. It was not a very cool thing for them. But if you don't do a good service, there's the risk. Last part I'm going to talk about is the emergency medicine point of view of my job. This is my ulcer. I have to do something with patients, remember? Diagnosis, treatment, disposition. The third part is you've got to go somewhere at 4 hours. You can't, it's closing time. I don't care if you go home, but you can't stay here. I can either admit everybody, and insurance companies sort that out. They don't really like that. Or I can discharge everybody, and God will sort them out. My lawyer doesn't like that. So you have to make a decision. Patients have to be admitted to the hospital, the right one has to go in, and patients have to go home. The right one has to go home. And you get that mixed up, and it doesn't go well for anybody. We do have tools for that. This is 80,000 patient analysis looking at different laboratory tests that we can do to make a decision. And I'm just going to show you some of these to clarify how important these decision pieces are. So BUN is a measure of how good your kidneys are working. Patients who come in with heart failure and their kidneys aren't working well do terribly. They die. This is the rate of who dies this week. 9% will be dead this week. But if you have good kidneys, 2%, 2.5% die. If you have a low blood pressure and a high creatinine, which is another measure of kidney function, 1 out of 4 is dead this week. If you have both of those low, 2% are dead. So these are tremendously valuable parameters that if we know the results, I can say these people in the red box need to be in the ICU. These people over here in this yellow box should be in a regular floor, and these people over here can go home or go to an observation unit where they go home in 24 hours after being cared for. But the idea is that we can distinctly determine these things if we know the numbers. These are troponin. This is a blood test of heart attack in patients with heart failure who have elevated troponin. That's the yellow line here. This is their death rate compared to the blue line. You want to be the lower death rate, the blue line here. This test takes about 15 minutes if it's done at the bedside. It takes about 90 minutes if it's not. And then you can compare these where both troponin and the heart failure hormone that I talked about, BNP, are low, you do very well. And if you don't, your death rate's 10% all these acutely. So with 3 laboratory parameters, I can decide, I can figure out who's going to live and who's going to die this week. And it's not like I can tell otherwise. Remember I showed you the diagnostic thing? I'm wrong 1 out of 4 times in the diagnosis. I can't even start treatment if I can't get the diagnosis right. So when you talk about point of care, the world of business is usually you can have any 2, faster, better, cheaper. When you talk about point of care, it's not the world of business because I can get all 3. I can do it faster, better, and cheaper than the old way. So that's why, as an emergency doc, I believe in point of care. Thank you.